Hello, in this episode we discuss cervicitis, the inflammation of uterine cervix. There are two types, infectious and non-infectious. What are the common etiologies of the infectious cervicitis? Chlamydia trachomatis, Neisseria gonorrhea, Mycoplasma genitalium, and Trichomonas vaginosis. What are the causes of non-infectious cervicitis? We have trauma, radiation, malignancy, or use of diaphragms or vaginal douching. Also remember foreign bodies and latex allergy. What are the clinical findings of cervicitis? I would like us to remember three findings that are different from what we see in vaginitis, vaginosis, because both conditions are associated with discharge and possible lower urinary tract symptoms. However, in cervicitis, we have mucopurulent discharge coming from the cervical os, while we don't have such a finding in colposcopy. We have just vaginal discharge in the vaginitis in the colposcopy. Another important finding of cervicitis is presence of endocervical friability or friable cervix. What is it? It's a cervix that bleeds easily upon contact, for example, when touched with a cotton applicator. A third finding that kind of overlaps with PID, so we need to be careful about that, is possible presence of Chandelier-sign, the cervical motion tenderness. But more important than that is presence of some sort of abnormal uterine bleeding, either in the form of intermenstrual bleeding or, most importantly, postcoital bleeding. Again, we could have dyspareunia and lower urinary tract symptoms such as dysuria, as seen in also vaginitis. Now, among all these symptoms, if a patient has which one of them, we need to evaluate for the possibility of PID. That is cervical motion tenderness. Though in PID we usually have fever, we usually have abdominal or pelvic pain, and also not only we have cervical motion tenderness, but we have adnexal tenderness. These are not present in simple cervicitis. That's not complicated to PID. So the previous ones, cervical discharge, friability, and postcoital bleeding, helps differentiate it from vaginitis, which is a differential of vaginal discharge, which could be cervical or just limited to vagina. On the other side, presence of fever or abdominal pelvic pain and adnexal tenderness supports PID in a case that has the symptoms of cervicitis plus these ones when need to rule out PID. Based on what we mentioned, if we are able to rule out vaginitis, vaginosis, and we are able to rule out PID, the diagnosis is basically clinical and the labs are just to support the diagnosis. Why understanding of this concept is important? Because we need to initiate the empiric treatment upon clinical clues in support of diagnosis without waiting for the results of the labs. What does the empiric treatment mean? It means the treatment for both Neisseria gonorrhea and Chlamydia trachomatis before the lab results are available. Is there any exception to the rule of initiating empiric antibiotic treatment? Yes, if the patient is low risk for the complications specifically and has reliable follow-up. For example, we know that the patient would be immediately available to initiate the antibiotic treatments upon test results availability. And if a third requirement is also met, and that is the low levels of local incidence of cervicitis, we can defer the empiric treatment and wait for the lab results. Again, all three of these conditions should be present. Patient has the symptoms, but for example has low risk for this, that is low risk sexual behavior mainly, has good follow-up, and epidemiologic data shows the local prevalence being low. What are the tests to perform? Wet mount microscopic exam, because as we mentioned, Trichomonas vaginalis is a possibility, but always we need to perform the nucleic acid amplification test for NG, Neisseria gonorrhea, and Chlamydia trachomatis. Okay, what is the antibiotic that's used most commonly for initiation of the empiric treatment? Well, we need to cover the Neisseria gonorrhea and Chlamydia trachomatis. So we use ceftriaxone for Neisseria and we use doxycycline for Chlamydia trachomatis. Now, there was initially a discussion that even if the patient later on was proven to have no Chlamydia trachomatis, because of the possibility of high rate of resistance among Neisseria gonorrhea to ceftriaxone, we need to still add a macrolide, which also covers chlamydia and also covers Neisseria. But recent data shows that Neisseria gonorrhea still demonstrates good susceptibility to ceftriaxone, so we do not need to worry about that, and we just add doxycycline for the chlamydia. Now, what are the antibiotics that cover the chlamydia trachomatis? We can use doxycycline, we can use azithromycin, we could use levofloxacin. So in what condition we should specifically and only use azithromycin? Remember, during pregnancy, doxycycline and fluoroquinolones are contraindicated, and so we need to use azithromycin for coverage of chlamydia trachomatis during pregnancy. So, put it simple, the empiric treatment for cervicitis during pregnancy is ceftriaxone, which is safe during pregnancy, plus azithromycin. We don't need to much worry about the dosing for now, but just remember azithromycin is a single oral dose, while both doxy and levofloxacin are 7-day dose. Likewise, ceftriaxone is given IM in a single dose. Now, a common scenario is that you are given a case in which one of the tests come back positive. It could be reported as gram-negative diplococci, but you are not getting any report of chlamydia, or just chlamydia testing is just not available. This is the situation where we need to not only cover for Neisseria gonorrhea, but also for chlamydia. Now, if we are dealing with only chlamydia trachomatis cervicitis, what would be the report of the gram stain? Urethral discharge in men or cervical discharge in women would show a lot of polymorphonuclear cells, but no bacteria. Why is it so? Because remember, chlamydias are intracellular pathogens. So in addition to the initial empiric treatment, as well as pregnancy antibiotic regimen, as well as gram stain results that we discussed, a fourth scenario could be a patient with no resolution of symptoms despite proper antibiotic treatment. How we approach this case? In this condition, we need to perform nucleic acid amplification test, but this time for Mycoplasma genitalium, and also rule out non-infectious causes of cervical pathologies, such as dysplasia or irradiation and irritation, etc. What are the recommendations for partner treatment? Because cervicitis is considered a sexual transmitted infection, partners should be treated, and both partners should abstain from sex for 1 week. Sixth scenario, the fifth one, was the partner treatment. Is the patient with symptoms and signs of cervicitis while having an IUD? And you are asked if the patient needs to remove the intrauterine device. The answer is no. We just treat these patients similar to other patients, with one exception. And that is if the culture or any of the tests come back positive for actinomyces. That's the only condition where we need to remove IUD in patients with cervicitis. Another scenario is a patient who has no lab findings supporting an infectious etiology. Therefore, we are thinking about irritant type cervicitis, and the patient happens to have a copper IUD. How do we treat this type of cervicitis? Remember, this type is treated by oral estrogens. Now, we talked about the treatment failure requirement for testing for Mycoplasma genitalium. What are the conditions in general in which we need to suspect this bug? Not only treatment failure, but also patients with HIV infection. How do we manage Mycoplasma genitalium? With moxifloxacin or high-dose azithromycin. A final scenario is a patient with all the signs and symptoms of cervicitis, as we discussed, also has punctate hemorrhages on the cervix. What is the management? Remember, punctate hemorrhage is another way to say the patient has a strawberry cervix, and that is diagnostic for Trichomonas vaginalis. Remember from the discussion we had in Vaginitis episode, right? So, diagnosis again made by wet mount microscopy. If needed, for example, equivocal results, we can also apply nucleic acid amplification test for Trichomonas. The treatment is metronidazole or tinidazole. Now, another scenario is you are having a patient with cervicitis during pregnancy, and you are asked what are the important factors to consider in the course of management of this patient. Remember, not only we should avoid doxycycline or fluoroquinolones, but we use azithromycin. The second important consideration is all patients with cervicitis during pregnancy, similar to urinary tract infection, if you remember, require a test of cure. And that's important to avoid obstetric or neonatal complications such as spontaneous abortion, preterm labor, or neonatal conjunctivitis, for example. Now, I feel I'm bound to mention at the end of this episode about this best tests in practice versus best tests in theory, as I mentioned, the gold standards, as well as the best screening test. I have a very little short episode for the screening for cervicitis in young women, which is another important aspect of diagnostics and workup. But we need to remember that the overall gold standard for diagnosis of chlamydia trachomatis and Neisseria gonorrhea from all body parts is the culture. Remember, Neisseria gonorrhea could involve almost any body part, pharyngitis, joint involvement, skin involvement, etc. However, it has been demonstrated that nucleic acid amplification tests have equal sensitivity and specificity for the genital secretions. That is, they are as strong as culture for assessment of UTI or STI and cervicitis. The second issue is which one is practical, and in practice they do not necessarily perform the culture for the UTI and STI and cervicitis, but they perform nucleic acid amplification tests. I reviewed many literature and updated material, and they do not necessarily talk about culture for diagnosis. Third point is to remember that the sample for nucleic acid amplification test could be from the endocervical region, or from the vaginal discharge, or from the urine. The most comfortable and the currently used DNA test is nucleic acid amplification test, which provides the results regardless of the site pretty quickly. However, you may hear other DNA-based tests such as DNA probe and immunofluorescence tests. These tests are usually time-consuming and may take up to 72 hours. And finally, a very important scenario is the screening. And in the screening, we will mention that the gold standard is nucleic acid amplification test for cervicitis. The exception that I mentioned was screening for cervicitis in kids who are suspected of child abuse. For screening in those scenarios of suspected child abuse, culture is preferred. Okay, hope this clarifies, and yes, this is our discussion of cervicitis.